Hello, everyone. Good afternoon. Thanks for joining us towards this presentations we'll be having for quite some time. This is the AFRH, the Association for Fertility and Reproductive Health. I am Dr. John Ekwani. I'm moderating this session. And together with me is Mrs. Inikbi, who will soon be joining us in some minutes' time. I want everybody to relax. Try to mute your mics, be calm, be attentive. And then on behalf of the Central Executive Committee of the Central EXCOs and the Academic Committee, we are welcoming all of you to this session of the AFRH clinical presentations. On board, we have a very distinguished fellow among us who is going to be presenting the topic at hand. We're looking at Dr. Temitope Akinola, who is a consultant gynecologist and obstetrician with keen interest in reproductive endocrinology, infertility, and fetal maternal medicine. He's a fellow of the West African College of Surgeons and a member of the Association for Fertility and Reproductive Health, AFRH. He is currently the head and director of obstetrics and gynecology at the Evercare Hospital, Lekki. He was a former head of department at the Al Rayyan General Hospital, Al Rayyan, Riyadh, Saudi Arabia. He had his undergraduate training at the prestigious University of Ibadan and postgraduate training at the University College Hospital, Ibadan, Oyo State. He has great passion for women's reproductive health and demonstrates this as a regular speaker at conferences that are women inclined. He is a certified family planning trainer by USH and Mare Stopes International. He is also a visiting director at Origin Fertility, Ikoyi. His hobby is playing golf and he likes to network as well. With great pleasure and with digital clap, let's invite Dr. Temitope Akinola to take the floor as he makes his presentation. Thank you very much.
Thank you. Thank you very much. Let me share my slides. Yeah, good evening, colleagues and senior colleagues. It gives me, with a high sense of humility and honor to present in the AFRH training committee webinar series. And we'll be taking a very, very important topic, endocrine disorders and infertility. As members of Association for Fertility and Reproductive Health, it's our passion to help a lot of families fulfill their heart desire, which is procreation. However, in trying to resolve part of the major causes of infertility, we meet patients with endocrine disorders every week, every day. We see patients who have disorders that affect the hormonal system, and these tend to have a high implication on their reproduction, on their ability to actually have babies or get pregnant. So we'll be talking today basically on the effect of the hormonal system on fertility, with key emphasis on specific endocrine disorders that we'll see. I want to start by introducing that the endocrine system is a system in the body that is made up of different glands, which releases a lot of chemicals that work at areas distant from where they are situated. Now, these organs, we are used to many of the organs that are involved in the endocrine system, but they are interrelated in their function. Their action actually extends beyond reproduction, but we'll try to see that a key understanding on the hormonal basis of these conditions plays a major role in trying to resolve, to understand the endocrine disorders. So like I mentioned, is a network of glands that releases chemical substances called hormones into the bloodstream. Where they act is actually distant from where these glands are recruited. They help to maintain homeostasis, which is internal balance. They regulate growth, they regulate metabolism, reproduction, and they work closely with the nervous system. So by virtue of the chemical substances related, they have other functions outside reproduction. And it will be good to actually see the interplay of these different hormones and how it affects our key concern, which is reproduction. By definition, infertility is defined as inability of a couple to achieve pregnancy after 12 months of regular, adequate intercourse. Now, even though this is due to different etiology, we have found out that there's male factor infertility, there's female factor infertility, but our topic today, endocrine disorders, plays a key role both in male and female infertility. Okay, when there are disorders with the hormonal system, it affects the ability of the woman to ovulate. This will affect the ability of the eggs to grow and to be released. It will affect even the ability of the fertilized egg to implant in the lining of the pregnancy. And even if the woman gets pregnant, it will affect the ability of that pregnancy to continue. And for the male, the disruption in these chemical substances also affects sperm production, affects the development of sexual secondary characteristics, and therefore you find out that it's like a dual etiology, not just affecting anovulation in women, it is a major contributor also to male infertility. So endocrine disorders have a major role in causing anovulatory infertility in women and also in men in causing male infertility. Now, I'm going to also start by having a pictorial representation of the endocrine system. I said it's a network of different organs or different things working together. We are used to the hypothalamus, the hypothalamus-pituitary ovarian axis. The hypothalamus is a very central mechanism, central organ in the endocrine system. The hypothalamus is responsible for the production of the GnRH, gonadotropin-releasing hormone, which is released in a pulsatile fashion. This gonadotropin-releasing hormone is what controls the production of follicle-stimulating hormone and luteinizing hormone by the anterior pituitary gland, which indirectly controls ovulation in women. The follicle-stimulating hormone produced by the pituitary gland is responsible for the growth of the follicles, while the luteinizing hormone is responsible for ovulation. Okay, now these same hormones also contribute to affect sperm production in men. So they have a dual, that's why sometimes the axis is referred to as hypothalamo-pituitary gonadal axis, not just pituitary ovarian, because they also have a way they can also affect male. So there's a general tendency that when we are talking about endocrine system and infertility, most of us are just looking at the anovulatory cause of infertility. But we should not forget that as practitioners, infertility is the problem of a couple. So as we are thinking about the effect on the woman, we should also be thinking about the effect on the man also. We also have the gonads themselves, the ovary and the testes. The ovary, very, very important, because the ovary plays a pivotal role in the release of the eggs, which is a central thing in anybody who is doing assisted reproductive technology. The quality of eggs is a major determinant of your outcome, is a major determinant of the embryos you get, is a determinant of whether the woman gets pregnant or not. So you find out that the hypothalamus affects the pituitary gland, while the pituitary gland will affect the ovary. Now, for the man also, you have the testes. Okay, so the luteinizing hormone also affects the production of testosterone, okay, which is produced in testes. So sperm production also can be altered by any disruption in this system. Now, there are certain organs also that may not directly fall under the hypothalamus-pituitary ovarian axis, but they are also endocrine glands which have other functions, outside reproduction. But their disorders contribute a major role to infertility. One of such is the thyroid gland. The thyroid gland is central in controlling metabolism. But whenever there's a disorder of the thyroid gland, it can cause anovulation. It can be a major contributor to infertility in a woman. The pancreas, the pancreas is a very special organ. We have what we call the endocrine pancreas and the exocrine pancreas. The exocrine pancreas refers to that part of the pancreas that is not involved in endocrine functions, But the endocrine part of pancreas produces insulin. Insulin to us is important to regulatory of glucose metabolism or glucose homeostasis. However, in some of the major disorders, we'll find out that it plays a major role because insulin resistance is a major characteristic of some of the anovulatory disorders in women. A central one is polycystic ovarian syndrome that we have, and also some hyperandrogenic states. So these organs, they have other functions, but when there's a disorder, it has a major role in causing disorders in women. So we're going to start with okay, this is still just the other overview, talking about the primary hormones produced by each gland. I had mentioned that the pancreas, the endocrine pancreas, produces insulin, thyroid gland produces thyroxine, testes produce testosterone, ovaries responsible for production of estrogen, adrenals are also very important, okay, and this is just a pictorial representation of the different organs and the predominant hormone that are produced by each one of them. Now, in addition, there are other hormones that are also produced. For example, you find out that even androgen being the male predominant hormone, women still have an acceptable amount of androgens that are expected in them. In fact, the aromatase enzyme works on the androgen to convert it to estrogen. So even though estrogen is the predominant feminine hormone, you find that there is an acceptable amount of androstenedione, which is the predominant male as androgen in women. And I've mentioned that you need it as a precursor even to produce estrogens. Okay, you have other things like inhibin also produced. Now, the uterus itself also produces prolactin and relaxin. Then, when the woman is pregnant, you have the production of progesterone from placenta, estrogens, then things like human placenta lactogen, human chorionic gonadotropin, and inhibin. So despite the fact that these are different organs which can produce different hormones, there's a central pathway in which some of them can control the act of reproduction in humans, and that's the hypothalamo-pituitary ovarian axis. And even those organs that are not within the hypothalamo-pituitary gonadal axis, through their own indirect effects, they can cause certain things in the bloodstream that may affect the fertility of men and women. Okay, and this is just a pictorial representation showing the effect of the hypothalamus on the anterior pituitary gland to produce the luteinizing hormone and the follicle stimulating hormone, and why the follicle stimulating hormones then acts on the ovaries to produce estrogen. And also, this pictorial representation also shows how negative feedback mechanism occurs. And that is why you see in a situation where you have a patient with premature ovarian failure, you see that the follicle stimulating hormone is very, very high because there's a compensatory drive on the anterior pituitary to compensate for that deficiency in the estrogen in the target organ. And that's why you see very high FSH in women who are approaching the menopause, or women with premature ovarian failure. The same thing also, as I'm talking about that, when we're looking at this description in women, we must not forget the corollary in men. It's not just about the woman alone. A disruption in the endocrine pathway or a disruption in this axis will also be a major contributor to male infertility. And male infertility, like we know, it's becoming having a higher percentage in terms of contribution towards infertility. In the literature, in developing countries, in the past, people used to quote 33%, but more recently now, people are quoting above 40% as a major contributor towards infertility. And this is actually even due to a lot of people have attributed this sudden increase to a lot of substances in our environment, which are called endocrine disrupting chemicals. So we found out that even when we are worried about chemical environment, pesticides, and things like that, a central mechanism in which these substances contribute towards infertility is still disrupting the endocrine system, which is our major focus of today. Now, this is also just a description of, I've mentioned that the gonadotropin releasing hormone, which is actually released in a pulsatile fashion, and now it stimulates the pituitary to produce the LH and FSH before it now acts on each of the gonad. In the case of the woman, acts on the ovary, and in the case of the woman, acts on the testis. So these are just pictorial representation of what I was describing on the hypothalamo-pituitary-ovarian axis. So the gonadotropin releasing hormone, I've mentioned that the FSH, follicle stimulating hormone, produced by the anterior pituitary, is very, very important in follicular growth, in the growth of the eggs. They also help to increase estrogen production. And in males, they also drive sperm production. FSH also plays a role also in male. In luteinizing hormone triggers ovulation, maintains corpus luteum and the production of progesterone, and it also stimulates testosterone production in males. The ovarian hormones, estrogen. We all know in assisted reproductive technology that the condition of the uterus is very, very, very important. And that's why when we are planning a patient also for embryo transfer, whether frozen embryo transfer, or we are preparing the patient for a fresh transfer, the lining of the womb is very, very important, which determines a major role whether pregnancy or implantation is going to occur at all. So estrogens helps to thicken the endometrium, and the preparation of the line of the endometrium is a very, very important thing in achieving pregnancy. So the estrogen is a major hormone that regulates this. It also regulates the FSH-LH through the feedback system. Remember what I said about positive and negative feedback system, whereby if you have a reduction in estrogen, the signal to the anterior pituitary is to compensate for more function. That's why you have an elevated FSH level, in people who are having premature ovarian failure. The estrogen also determines the condition of the cervical mucus for sperm transfer. Now, progesterone, it is good for the endometrium to be well prepared and taken. Maintaining that endometrium also for pregnancy is very, very important. Whether that woman also gets pregnant or not, ensuring that that woman also does not miscarry, or she doesn't have an early miscarriage. So you find out that endocrine disorders are not just important in infertility, they are also important in subfertility or in patients with recurrent miscarriages. So the progesterone, very, very important in stabilizing early pregnancy, and low levels have been indicated in luteal phase defects. They are also supporting endocrine hormones like prolactin, and I said that even some of these organs, hormones that are hormones produced by organs that are not central in the hypothalamo-pituitary-ovarian axis, have an indirect way they can also affect ovulation. High prolactin levels will suppress the GnRH to cause problem with ovulation, and that's why hyperprolactinemia, the central mechanism by which hyperprolactinemia affects infertility, is through an ovulation. Okay, hyperprolactinemia can affect infertility by causing an ovulation, and this can also be caused by excessive stress, hypothyroidism, and prolactinemia. Thyroid hormones play a major role in regulating metabolism, but both the hypothyroid state and the hyperthyroid state can cause anovulatory infertility. So it's important to look at the endocrine system as a network of glands, not just a central one that controls the act of reproduction in women. Okay, and we also have so I'm going to talk on other organs. Insulin, I was mentioning that the pancreas has the exocrine and the endocrine pancreas. Even though the pancreas is not part of the hypothalamo-pituitary-ovarian axis, but the production of insulin by the endocrine pancreas makes a major contribution towards reproduction and fertility in generally. Relative hyperinsulinemia or insulin resistance you have in certain conditions such as the polycystic ovarian syndrome or hyperandrogenic states contributes to an ovulatory infertility, and which affects both egg quality and ovulation. You also have the androgens. There's a minimal amount of androgens expected in women. Androgen being the male, a predominant male hormone, does not mean it's not present in women. You need the aromatase enzyme to work on androgens to convert it to estrogens. But when you have a situation whereby you have an increase in the level of dihydroepiandrosterone, DHEAS, which is the predominant androgen in women, you have hyperandrogenic states. And these hyperandrogenic states cause anovulatory infertility in women, and we would get to know the clinical features when we get to the specific disorders later on in this presentation. Other things also, cortisol, stress-related infertility. By stress, we increase the cortisol level, and this can actually suppress GnRH agonist production. This just like the physiology or the endocrine basis of most of these disorders, without which we cannot understand how the different disorders affect infertility. I'm going to start by the commonest endocrine disorder in women, polycystic ovarian syndrome. I am aware that most of us will see PCOS patients every week. In fact, now with things about changes in lifestyle and all that, we are beginning to see many more PCOS patients with polycystic ovarian syndromes. So we're going to talk about polycystic ovarian syndrome, hypothyroidism, hyperthyroidism, adrenal gland disorders, as well as pituitary gland disorders. PCOS and infertility. Polycystic ovarian syndrome is a common endocrine disorder affecting ovulation, and is characterized by hyperandrogenism, insulin resistance, and the features are majorly anovulation and metabolic syndrome. The patient may present with history of oligomenorrhea. Some of them may not even have oligomenorrhea. They may have prolonged menstrual flow, but the common thing about them is menstrual irregularity. They may also present with things like hirsutism. They may present with facial acne, and some of them may also present with an history of unintentional weight gain. Okay, unintentional weight gain. Now, it's important to know that not all PCOS patients will have the characteristic high BMI. Disorders include presence of oligo or anovulation, clinical or biochemical evidence of hyperandrogenism, and evidence of polycystic ovaries on ultrasound. Okay, now it's a major contributor to anovulatory infertility in women. Why it is established that not all PCOS patients will struggle with infertility. The early recognition of PCOS and actual giving them treatment options makes a major role in actually trying to solve most of the problems that these patients have. So even for those patients who are not yet thinking about fertility, when diagnosed early with PCOS, stabilizing their cycles, doing an hormonal profile, lifestyle modification, trying to achieve a body mass index that is good for their ovulation, involving the dietitian very early, involving the endocrine physician, checking their blood sugar to ensure there are no other features of plurimetabolic syndrome, is a very central, improving life outcomes when central to the start giving birth. I'm not inclined to them, when we see some of these people, to let them know the relationship between age and fertility, so that they can actually make informed decisions on time when their egg reserve is still very, very. Now, management of polycystic ovarian syndrome for fertility, we start with things like weight loss, exercise. We should also know that we have quite a number of patients who are going to be having clomiphene citrate resistant PCOS. So sometimes a clomiphene citrate might have been abused even in the society. Patients that do not need it, even using for ovulation induction. But some patients may need more than that. Even if you want to start with first-line management of first-line ovulation induction for anovulatory infertility. For the patient who has clomiphene citrate resistant PCOS, you may have to move to things like letrozole. Okay, for them for ovulation induction, and they may now, some other patients may end up with gonadotropins, and it's important to also state that it's becoming also a leading indication for assisted reproductive technology, especially IVF. So a patient who has polycystic ovarian syndrome should know about the different options available. When these patients come to see us in the clinic, it's important for them to be well diagnosed. Okay, it's important for them to have a hormonal profile done, their FSH, their LH, even their ovarian reserve, and they should also have ultrasound done to assess the state of the follicles, assess their endometrium, and all that. And it's important to know that it's a multidisciplinary management. Patients with PCOS, they should be co-managed with an endocrine physician. The dietitian should be involved in their care. Some of them may even have to see bariatric surgeons. I've had a patient with weight of 152 kilogram, 148 kilogram, 152, 154, trying to achieve fertility. Now, for this kind of patient, they have to think about what are the realistic options that can drop that weight drastically. This patient had actually tried things like going to the gym, exercise, but you are talking about something 152, 148 kilograms, and it wasn't working. This patient eventually had to actually see a pediatric surgeon, and patient did a sleeve gastrectomy, and she had significant reduction in her weight. So weight management or management of obesity in PCOS is multidisciplinary in nature, and we as gynecologists or as fertility physicians or people passionate in reproductive health should make sure that these patients have the full access to the multidisciplinary network. If the patient needs to see an endocrine physician, let her be reviewed by an endocrinologist. If the patient needs to see a dietitian, let's say a dietitian. The patient needs to benefit from a pediatric surgeon. It's a multidisciplinary team, it's a teamwork. That a patient should not be denied other options of achieving reproductive potential, because eventually when you have a satisfactory BMI, it will even help to improve your outcome even when you are planning assisted reproductive technology for these patients. A central one also is diabetes. Now, diabetic patients, we're going to be seeing more, especially because of lifestyle modification. So it's important for us to screen early and diagnose patients with diabetes. Now, why is it important for us to actually achieve a very significant control of a patient who is diabetic? Even eventually the patient does an IVF, if the diabetes is not well controlled, you're going to have poor outcomes. You may have an early first trimester miscarriage. You may have a patient who's at risk of having anomalies. And that's why there's a targeted hemoglobin A1C levels that must be achieved. Once it exceeds a particular value, the increase of having congenital anomalies are very, very high. So the management of all these endocrine disorders is multidisciplinary. So it's very, very important to achieve a good control before the patient even starts making plans for assisted reproductive technology. In fact, some of them need to actually get a bill of clearance from the endocrine physician to ensure that the blood sugar is well stabilized. If the patient needs to be on metformin, some of them will have to be on insulin. Dietitians, professional dietitians have to be involved in their care. So insulin acts on the thicker cells to produce, to cause androgen production, and hyperinsulinemia reduces sex hormone binding globulin, which increases the free testosterone in women. This increased level of free testosterone will result in anovulation and also result in poor oocyte quality. It will also cause menstrual irregularities, and so therefore it is a central mechanism in PCOS-related infertility. So the same hyperinsulinemia contributing in PCOS is the same thing also in diabetes and infertility. Okay, so I've talked about the fact that diabetic women not only have reduced oocyte quality, the poor glycemic control affects the hypothalamo-pituitary signaling sequence or the axis. They also have an increased rate of early pregnancy loss, and it can be frustrating for a patient to have had positive pregnancy test, scan, and for the patient to keep having repeated miscarriages due to an uncontrolled endocrine disorder. These clinical effects not only lower implantation rates, they also contribute to fetal losses, which can occur whether in first trimester, second trimester. They can even be a cause of sudden fetal death in the patient in the third trimester. So it's important for that patient to have fasting glucose done, OGTT, and the glycated hemoglobin gives us a higher index of what the control has been over a longer period of time. Now, management and preconception optimization. I've mentioned about weight loss, and I said in achieving weight loss, it's not just about telling them go to the gym dietitian. It's an MDT thing. You made the weight control or weight obesity management involves a lot of specialists, even the psychologists, because the patient may have a low self-esteem. The bariatric surgeon, who can insert a balloon for the patient, intragastric balloon, which sometimes gives a control for the patient who doesn't want to do a sleeve gastrectomy. Also has been shown also as a bariatric surgery option for women with morbid obesity. I'm talking about people with weight exceeding 140, 150. The dietitian is very, very important. Medical management, I've mentioned about things like metformin and all that. Then also for these patients, some of them would have tried ovulation induction, even by general gynecologists, before seeing a fertility physician or seeing a gynecologist who has interest in infertility. And therefore, when they are coming to see you and you are still talking about letrozole and clomid, they will be telling you they've done all that. They are coming out because they are ready for assisted reproductive technology. It's important to ensure that these conditions are well maintained before you start the process of trying to of controlled ovarian stimulation or planning them for IVF. Now, pregnancy considerations. We should avoid poorly controlled diabetes, and to know that poorly controlled diabetes increases even the risk of congenital anomalies. That is a major trauma to that patient. If that patient, having tried to achieve that pregnancy all the while, now has a baby that has multiple congenital anomalies, that now becomes a major problem for them. Thyroid disorders and infertility. I mentioned that the thyroid gland produces triiodothyronine and thyroxine, and these are central in regulation of metabolism. But the thyroid hormones also have a way they can suppress ovulation. And how is that done? When there's a problem with when you have an increase in the thyroid stimulating hormone, that can increase prolactin and suppress the gonadotropin releasing hormone, which is produced by the hypothalamus. Normal thyroid function is required for luteal support and early pregnancy. Both hypo and hyperthyroidism disrupt menstrual cyclicity, and it's also important to know that some patients who are even having recurrent miscarriages or problems with implantation may be having what we call autoimmune thyroiditis due to production of thyroid antibodies. So that also is a thyroid disorder that contributes to subfertility. So this hypothyroidism and infertility. The thyroid hormones also play a role in causing altered endometrial receptivity and the luteal phase defect also from low progesterone. Okay, so it's important for the patient to have a T3, T4, TSH checked, and also where thyroid autoantibodies can be checked, this can be done. Treat patient with levothyroxine to keep TSH less than 2.5 milliliter per liter in those trying to conceive. Reassess the TSH every 4 to 6 weeks. It's important to say that the gynecologists, you are not the one that will be doing this. We have internal physicians, we have physicians, internal medicine doctors who have specialized in endocrinology, who you should actually be co-managing these patients with it. We should try to devolve the practice of MDT, multidisciplinary approach. So as the patient is seeing you, the patient should also see an endocrine physician so that you can get good outcomes before planning your controlled ovarian stimulation. Excessive thyroid hormones will increase the sex hormone binding globulin and disrupt the estrogen balance. The gonadotropin hormone dysfunction will cause irregular cycles. So the role should be, you should treat the hyperthyroidism before conception, and medications also need to be changed. So if a patient is on an anti-thyroid medication in pregnancy, as long as her pregnancy is confirmed, she needs to quickly confirm with her gynecologist, with her obstetrician, whether she could continue, because some of those medications may cause teratogenic effects. So it's important to manage these patients with endocrine physicians, monitor their TSH, their FT12 level, and avoid over treatment. The adrenal glands also, they contribute a lot to infertility. Adrenal gland may not be under the hypothalamus pituitary gonadal axis. They also produce androgen, predominantly DHEAS, and aldosterone. And we know that excess adrenal androgen contributes to anovulation and the non-classical 21-hydroxylase deficiency syndrome. So both adrenal tumors, and some adrenal disorders can mimic polycystic ovarian syndrome. That is why it is not a good practice to assume that every patient who presents with an hyperandrogenic clinical feature is PCOS. There are other causes of hyperandrogenism apart from polycystic ovarian syndrome. And these patients need to be apart from physical examination, you need to actually run your biochemistry, clinical biochemistry. Sometimes you may also need to involve a chemical pathologist, even in actually trying to find out the primary disorder that they have. So some people may say, oh, why do I have to diagnose, or why do I have to stress myself when I can just do an IVF? It's because even if these disorders are not well maintained or well regulated or checked, even when that patient achieves pregnancy, these disorders will contribute to fetal loss. They will contribute to miscarriage. And when even the pregnancy is not miscarried, some of them will contribute to problems of congenital anomalies. So that's why it's very important for us to actually ensure that patients are properly diagnosed and look out for endocrine disorders when present. You have the non-classic congenital adrenal hyperplasia, where you talk about other features. Like I mentioned, hirsutism acne is not only pathognomonic or PCOS, you are having it also in the non-classic congenital adrenal hyperplasia. So you have also Cushing syndrome, which also there's insulin resistance and there's increase in ovarian androgens. So you might need to actually run the full biochemistry, run cortisol test, run the ACTH stimulation test, non-class and check the cortisol level and DHEAS level. And honestly speaking, when a full hormonal profile is done that involves all these tests, it is very, very easy. It makes more sense for that patient when that patient is co-managed together, because you can discuss with an endocrine physician. You can also discuss with the chemical pathologist in actually even achieving it, arriving at diagnosis. You also have other things that can cause androgen excess, androgen secreting tumors. Very high level of DHEAS can happen in androgen secreting tumors, and some of them can present also cause infertility. Hyperaldosteronism also can have an indirect effect via hypertension, or if we call it hypertension. So when you see those features also with hypertension, you should also be thinking of the adrenals also. So treat hormone secretory tumors surgically. Some of them may have to be treated surgically. Normalizing androgen levels before you do ovulation restoration, and consider ovulation induction when normalized in them. It's also important to know that there are pituitary disorders. Pituitary disorders, the pituitary gland produces FSH, LH. I've mentioned that. Major pituitary disorders can include things like hypopituitarism, the concept of hypogonadotropic hypogonadism. You also have hyperprolactinemia. You also have pituitary tumors, Sheehan syndrome. That in that. So you have other things, hyperprolactinemia, clinical features of hyperprolactinemia, galactoria, amenorrhea, infertility, and this should be suspected in patients where you have very, very high prolactin levels. Okay, the patient, there are other things that can actually increase prolactin level, like stress, vigorous exercise, and all that. But once you have very, very, very high levels, they should be investigated for further. And the management include measuring serum prolactin, do TSH, do an MRI for suspected prolactinomas. And I must also mention that you may also have to involve the neurosurgeon in the management of patients, especially those ones with pituitary macroadenomas. Okay? Now, for the hypopituitarism, low FSH can cause an ovulation. I mentioned that the causes could also include surgery, radiation, infiltrated non-functioning adenomas. So you find out that endocrine disorder is a multidisciplinary thing that can involve other specialties in their care. Okay, and it's important to do a proper diagnostic evaluation for the patient, take a detailed history, do physical examination, and you do your do laboratory tests for the patient. Let me also mention that treatment options, we've talked about things like lifestyle modification, their diet, exercise, stress management, hormone replacement therapy, and all that. While we are practitioners and members of AFRH, a lot of them will now come to meet us for assisted reproductive technology. We should let these patients know the options available. Some of them need to make informed decisions very early about the options of freezing their eggs. Some actually, and make decisions very, very early when they still have high chances. And those of them where the egg reserve is still very poor should consider the option of third-party gamete donation, donor eggs for them, and make realistic decisions for them to achieve their baby, to achieve pregnancy. So ART such as IVF can help to overcome infertility-related treatment, but it's important to know that before planning them for all this process of controlled ovarian stimulation and all that, we should ensure that lifestyle changes are done, maintain healthy weight, exercise regularly, they should manage stress, and there should be a balanced diet, and they should also see other obstetricians that are other specialists that are involved in the management of endocrine disorders. So endocrine disorders can significantly impact fertility, but diagnosis and treatment can improve chances of conception. And these are my references, books, review articles, and some journal articles also. Thank you so much for the time.
All right, thank you so much, Dr. Akinola, for that lucid presentation. We are quite thankful for that presentation. Thank you so much. On behalf of the AFRH, especially the academic committee, we thank you for that presentation. I am sure that we'll have one or two questions or comments. I've not seen any on the chat section. Let me check the Q&A side to see if anybody has anything. Okay, nobody has posted anything on the question and answer and on the chat section. Let me see. Questions. While we're waiting for questions, I don't know whether Mrs. Inikwi has joined us. I can't see her on the platform. I don't know whether she has network issues or something. Questions, comments. Okay, question. Let me see Q and answer. Okay, somebody has asked a question here. And he says, does natural remedies work for PCOS? Does natural remedies work for PCOS?
Yeah.
Can you give some comments on that?
Management for PCOS. We know that, well, there have been a lot of concern, or people are trying a lot of new products, and some of these products are appearing a little bit herbal. You know, honestly speaking, some of them contain things like myonisitol. And you know that myonisitol is very central in helping patients with PCOS. So the more matters is that if any product is being marketed that's different from orthodox medicine, they may have to be tried, subjected to clinical trials before we can actually conclude whether they work or not. The patient with PCOS, we know that diet is very important. In fact, when you see a dietitian, depending on the patient's BMI, they place the patient on particular diets. But in terms of whether there are certain foods and other, maybe she's referring to other natural products or plants or herbal stuff, they may need to be subjected a lot to clinical trials before one can validate whether these things actually work or not. But it's not impossible, because even the myonisitol we have in some of these products they are present in some of the natural plants we have in nature.
All right, thank you so much. There's another question here. Is there a specific recommended body mass index for one trying to conceive?
Well, BMI for a patient trying to conceive, we also depend on the race. And we also depend also on quite a lot of things, presence of conditions. But usually you will, it's a decision that has to be taken not just in isolation. It has to be taken in combination with review by your endocrine physician and your dietitian and your gynecologist. We know that outcomes, even pregnancy outcomes, are actually achieved better when the patient is actually less than 25 kilogram per meter square. Okay, you have anything more than 25 or 29, the patient is now tending towards being overweight. More than 30, you now talk of being obese. So actually, it's a relative thing, which may also depend on the what has been the pre-existing weight or BMI of that particular individual. But ultimately, anything 25 should be fine.
All right, thank you so much for that answer. We have another question here. Please, what's the first line of treatment for PCOS patients who are in their early 20s and they are not planning to conceive? Let me take that again. Please, what's the best first line treatment for PCOS patients who are in their early 20s and they are not planning to conceive?
in their early 20s not trying to they should be encouraged to start with things like diet, lifestyle modification, and also we use combined oral contraceptive pills a lot. Whether the Yasmin or the microgynon, we use that to stabilize the cycle. And it's important to tell them the correct way to use these combined OCPs. We give sometimes for like 3 months, stop, while we repeat an hormonal profile. The combined oral contraceptive pill helps to stabilize the cycle for that individual, especially for that patient with menstrual irregularity. Now, not all of them will require pills, but combined OCP will actually help those ones who have menstrual irregularities. It will help those with dysmenorrhea. It will help to stabilize their cycle before you with combined oral contraceptive.
All right. Thank you so much. There's another question here. What is the natural way to increase ovulation without using clomiphene citrate or letrozole? Natural way of increasing ovulation without using clomiphene citrate or letrozole. Sorry, am I audible?
Yes, actually.
Okay. I don't know whether it's from my end. I can't hear him. I can't hear the presenter.
Oh, okay. Can you hear me?
I can hear you now. Sorry, are you speaking? I can't hear you again.
Yes, I'm speaking at the moment. Hello, can you hear?
Yes, I just dropped a question. I said, what is the natural way to increase ovulation without using clomiphene citrate or letrozole? I'm not sure she's speaking.
Okay,
I
I'm
can't
speaking.
hear I can't hear him. I don't know why. I
Oh,
don't know why. I don't know why I cannot hear him.
hey, can you hear me now?
Yes, I can hear you,
Can you-
but you have not been speaking. I want to
Oh, I'm speaking.
I'm,
Maybe.
I only hear you when you say, "Can you hear me now?" And that's all.
Oh, okay. So I was saying that for a patient who has a problem with ovulation or an ovulatory disorder, lifestyle modification plays a major role. Okay, weight loss, diet. We also even help to achieve. It's not just about medication. That's why we talk about things like achieving an LD BMI. Weight loss and diet is a very central mechanism. These are natural things that can be done even before the patient starts active ovulation induction agents.
Okay. All right. Let me take the other question. Uh, for a healthy woman without any issues of infertility, is there any supplement that could aid conception?
Okay. And well, these are just general advices we give to women pre-conception. A woman who says she doesn't have any problem with fertility and preparing for conception, we tell them to take their vitamin E because vitamin E is very, very central in reproduction. Folic acid supplementation also should be commenced before before trying to get pregnant. So vitamin E plays a strong role, and there are actually a lot of multivitamin supplements that have a lot of these things that it can be commenced before the woman achieves conception. Okay, now for that naturally now we now have newer products. Okay, we have newer products that contains agents like myonisitol, which helps egg quality. In some women will benefit from that. So there are pharmacological agents that are present that contain myonisitol that can actually help egg quality that women can actually even take even while achieving conception, even when they are not yet ready to start preparing for an assisted reproductive technology cycle.
All right, thank you so much. And then there's this question here. Does prolactin, particularly when elevated due to a prolactin secreting tumor, affect estrogen levels? Can this impact estrogen production during IVF, since adequate estrogen is needed for optimal endometrial thickness? Also, can a patient develop high prolactin as a side effect of ovarian stimulation drugs during IVF, even if our prolactin level was normal before treatment? So there are three questions here. Number one is, does prolactin, particularly when elevated due to a prolactin secreting tumor, affect estrogen levels?
Yeah. Yeah, that's right. That affects. I think I mentioned the central mechanism how that is done. Hyperprolactinemia affects sex hormone binding globulin, and that affects ovulation. So that can affect estrogen levels, and therefore it's also important for that. That's why it is good for the prolactinemia to be managed even first before trying to rush the patient for an IVF cycle. And this can also play a major role in also affecting also your implantation rates. Then I didn't get the other part of the question on
Yeah, don't
elevated
worry.
prolactin.
I'll take it now. Can this impact estrogen production during IVF, since adequate estrogen level is needed for optimal endometrial thickness? So I think I think that answers it, if I'm
Yeah,
not
okay.
mistaken.
Yeah.
Then the last part of the question is also, can a patient develop high prolactin as a side effect of ovarian stimulation drugs? Sorry, I don't know whether I got that.
Hello, take that again, please. Can a patient develop high prolactin
Can a
level?
patient develop high prolactin levels as a side effect of ovarian stimulation during IVF? Even
Well,
if our prolactin level was normal before treatment.
no, I'm not aware of that.
Okay, all right.
Yeah.
All right, then there is this question again. Is it normal for a 34-year-old lady to regularly ovulate, see the egg white discharge without menstruating regularly?
Without menstruating. Oh, yeah. Okay. So now let me explain this. The fact the fact that a patient menstruates every time does not is not both are not mutually exclusive. Okay, you don't assume that because a patient is menstruating regularly, she doesn't have ovulatory problem. Okay, and both are, and it's also possible, and the converse also does not hold. So the presence of regular cycle does not mean that you should assume that the patient does not have a problem with ovulation. It is possible for a patient even to have a problem with ovulation and still be menstruating every month. The only challenge is that if you in our history taking, the history of menstrual irregularity, especially oligomenorrhea, makes us to start thinking first of problem of anovulation. But the fact that you are menstruating regularly does not exclude an ovulatory problem. So it's not mutually exclusive.
All right. Thank you so much. Let me check the other side. Okay, this person is asking a question of how many milligrams of vitamin E can someone take as preconception drug?
We usually give 1,000 1,000 international unit capsule, one daily. The comes
Okay.
usually in international unit, yeah, a capsule daily.
All right. Thank you so much. I think you have attended to all the questions I can see here. I don't think there's any that is pending. So thank you very much. I can see I can see some digital claps
There's
along
other
the
questions
line.
in the chat.
In the chat, which other? I can't see. I've answered all.
About two questions.
Sorry, which
Can you
one?
scroll up? Can you scroll up?
He has answered all those questions.
Okay,
He has
that's
answered
fine.
all of them. Yes. I was taking it sequentially, so he has answered all of them, both at the
Okay,
chat
thank
section
you.
and the Q&A. So I think we have actually come to the question and answer session. Many thanks, Dr. Akinola. Thanking you on behalf of the AFRH Educational Committee and the Central Committee, the Central Schools as well, for giving us this very wonderful presentation. We truly appreciate giving us your time and sharing the wealth of your knowledge in building us up in our fertility practices in our different clinics and centers of experience. So we're supposed to have Mrs. Inikwi joining us here to give some announcements, but it looks like if she's not available, Secretariat, Mrs. Yejide, you may have to stand in to do that. Am I right?
Yes, you are. Good evening, everyone.
All right, thank you.
Unfortunately, Mrs. Nipe could not join us for today's session, so I'll be taking the announcements shortly. So, for the purpose of today's announcement, we have Abuja conference next year. It's actually a regional conference. It's the second AFFS regional conference. Abuja 2026 is holding between September 23rd and 25 next year in Abuja. Abuja Continental Hotel, precisely. That's the venue. As the webinar progresses, we'll give you more information regarding the conference for next year. But kindly save the date, September 23rd to 25th is Abuja 2026 conference date. We also, the AFRH platform is also, app platform is also available for our use. Once we register, we can also download our profile and fill out the details to get acquainted with all the information regarding the website and the AFRH conference itself. And getting to be a member, you can make your payments online, you can do offline or online payments, and you can register to become a new member. You can also subscribe to renew your membership subscription. And also, if you are also enjoying, to please join us on all our social media platforms, the Twitter platform, the Instagram, the Facebook. Yes, you can join us to see what we do. All our programs, all our events will also be published on all the social media platforms. You can join us and be a part of this event. So the next webinar will be on the 10th of December. That's next week, Wednesday, and that will be the last webinar for this year, as well as the last webinar for the clinical series. So please make it time to join us. Same time, same venue. It will be communicated via the platforms, especially on the WhatsApp platform and all the social media platforms. You get to see the flyer and the registration details. Thank you so much for joining. We look forward to seeing you next week. Make it a date with us. Thank you. Over to you, Dr. Johnny Kwan.
All right, thank you so much, Mrs. Yejide, for that, for standing in for Mrs. Inikwi. We thank the presenter and we all thank all the attendees, the Central Executive, the ESCOs, and the academic committee for arranging this. And it has been a long journey from the beginning of the year till now, and I can't believe we're almost rounding up. So thank you, everybody, for being part of this, and we look forward to seeing you next time. Have a great evening.